Afternoon, everybody. Thanks for giving us this opportunity. So we're here today as the Specialist Orthopaedic Alliance, hoping to put forward a vanguard proposal to become the National Orthopaedic Alliance. Just introducing myself and the team. I'm Wendy Farrington-Chadd. I'm the Chief Executive at the Robert Jones and Agnes Hunt Orthopaedic Foundation Trust, and I'm Lead Chief Executive for the Specialist Orthopaedic Alliance. Colleagues here today, Rob Hurd, who's the Chief Exec at the Royal National Orthopaedic Hospital, colleagues from the Royal Orthopaedic Hospital in Birmingham, and from the Specialist Orthopaedic Alliance. So, who are the Specialist Orthopaedic Alliance? We're a well-established alliance of 14 plus specialist and large volume centres in the UK, founded originally by 5 specialist orthopaedic centres. We work effectively together as a trade organisation, mainly around best practice and benchmarking. We have different organisational forms as members, and in that way we can actually traverse across many areas and challenges in the delivery of care. We're here today in a vanguard proposal as 3 centres, 2 foundation trusts, 1 NHS trust, providing high quality and high volumes of orthopaedic care. We see the vanguard process as a way to put pace and scale around some of the work we've been doing as an alliance, particularly in developing new models of care and the Getting It Right First Time national programme. So why vanguard? Orthopaedics is the biggest single surgical specialty, as you'll all know. It's one of the biggest spend areas, one of the longest wait areas, and one of the biggest challenges for commissioners. There's huge scope, particularly in elective orthopaedics, for standardisation and to move at scale and pace in establishing good quality practice. We're keen to explore how we, as 3 organisations, could act effectively as a testbed in taking some of that national work forward to codify best practice, to develop ways of looking at reducing variation in both cost and in quality, ultimately to improve the quality of care for all patients receiving orthopaedic surgery, whether that's in a specialist centre, in a district general hospital or in a teaching hospital. We need vanguard status simply to give us that scale and spread, and that's where we're looking for support. I'm going to pass over to Rob, who's going to run through the areas that we particularly want to look at as part of this bid. Thanks, Rob.
Thank you, Wendy. So the Vanguard, National Orthopaedic Alliance Vanguard bid is going to do 3 specific things. As Wendy says, we have an existing collaboration already, but we want to strengthen that existing national and international collaboration model to provide a kite mark of excellence in orthopaedics. We want to provide a transparent communication of what good looks like in orthopaedics, a manual of excellence in orthopaedics across the NHS in England. That will be across preoperative assessment, low infection rates, low length of stay, reducing litigation rates, reducing infection. There is massive opportunity in orthopaedics in this country to improve the lot of our patients and to make best value for the taxpayer. These are the principles of getting it right first time. Our patient groups will be engaged nationally, just not at a local level. We will engage across national groups to inform our work. And we will provide a simplified consolidation of the myriad of international best practice guidance, royal colleges, professional associations, clinical reference groups, Lord Carter's efficiency programme, monitors optimal models of care, and we will translate that into what good looks like in orthopaedics in simple terms for patients and staff who want the tools to do a good job for their patients. So having defined that, thing 2 we will do is we will provide a highly infectious and transparent model of excellence. So across the 3 core members that we will start, we will cascade that across the other founder members and working closely with the Wrightington Hospital and the Nuffield Orthopaedic Centre, and across our 14 members, which include independent sector partners as well as members from overseas. And at the core of this is to eliminate the unwarranted variation in practice and for clinicians and staff to have the information and the tools to do the job, to reduce that and to do a better job. For example, the money that we spend in prosthesis, for example, the variation in infection rates, we can help collaborations, health economies across the country with information, with methodologies, with good care pathways and examples of best practice internationally. And finally, the final thing we will do is to look at exploring the role of specialist centres nationally in the system landscape, what levers we can use to get the accelerated pace of change towards these good outcomes for patients that we're describing. And we'll explore our role as a potential national prime contractor of specialised services as major providers of the specialised services of orthopaedics across this country. The model will help set standards that patients and staff can rally behind, the outstanding outcomes that are possible with the right tools to do the job, the right staff at the right time, getting it right first time, a project on which we are leading. And we hope to rally collectively behind that together across the UK, across the specialist centres.
Okay, thanks, Rob. So there's a lot we'd like to do and we're really excited about. And as 3 providers, we'd really like to be the test bed for some of this work, give it scale and spread at a national level. Rob's mentioned the kite mark, and I think for coming right back to patients and the benefits, if you had through your orthopaedic procedure a kite mark logo around a standard of quality and excellence that you could trust as a patient, then I think that's a really great thing that we could give to this process, and we're looking for your support. Thank you.
Caught me off. Oh, I'll do it. Simon Cowell would hate that one. I left the microphone. Could we have questions, please? Thank you. I can see just in the dark over there. Number table 25, please.
Julie Tasker, patient rep from Nottinghamshire. You're talking about getting it right first time. What's going to happen if it doesn't get right first time?
Sorry,
What will happen if it doesn't get right first time?
well, clearly there have to be pathways through to the right experts that deal with the complications that occur. But I think what we have is we work in silos across specialist centres, tertiary centres. We have a wealth of information as to what's gone wrong to our patients. When I walk around my hospital and find countless case studies of things that have gone wrong in the pathway along the way, and those are not only tragic for the patient but cost us a lot of money to put right. So I think using the whole collaboration as a way of feeding back, learning what has gone wrong, getting back to the source of the problem, so it will drive forward improvement and change. What's caused this is describing what can be achieved, and transparently. I think there's a lot of talk today about variation. We seem to accept there is unwarranted variation. Do we really get out to the clinicians? Do we really get out to our patients and explain what we mean by unwarranted variation? Do people really understand that there are 2% infection rates in this country, there are 0.2% infection rates in this country regularly achieved and regularly at variance with each other? And I think that sort of information to clinicians and staff and what can be achieved with support of our patient group to simplify the complex landscape that describes what pathways are in orthopaedics has a major potential to help patients and save a lot of money.
Samantha?
Thank you, Anthony. So can we just pretend I'm a taxpayer, and which I am, and a patient?
Are you?
You're a taxpayer.
Even at NHS England, you pay taxes.
I'm just letting go my nom-don status. I'm a taxpayer. Why isn't it happening anyway? So everything you've described is spot on. Nobody can question it, but shouldn't we really just be doing it anyway? Why do you need to be a vanguard to reduce the variation? That's my first question, as I'll get my coat. The second one is, what are the barriers to really making it happen that are getting in the way?
So I think one of the biggest factors here, and having spoken to thousands of clinicians in orthopaedics across this country, is the acceptance of the status quo and the way things have been done before, and that's the outcome. And there's nothing with the sense of helplessness of that's what. But then people don't know how their outcomes compare to other centres. People don't know what can be achieved. And I think that transparency, the reason it hasn't happened before, because we've been competing, we complacently think that we're providing good outcomes, we complacently think, I've lost count of the number of people who say we get the best deal on the amount of money we spend for a hip implant in every centre across this country. people do not know, and people do not know their outcomes. And I think getting that out to staff and clinicians at a real level that's transparent to them, and people will naturally, the offset to the lack of competition that we may have now, we're all collaborating to save the NHS, will be the driver of good information, of wanting to provide a good service for our patients, and exposing where that isn't the case in a real and meaningful way.
This is table 9, then table 18, and if we have time, then it'll be table 19.
One of the things we learned through our cancer work is the impact of change on other systems and other places and how you help them. So I could imagine there'd be quite a lot of potential change reflected in your proposals. How are you going to feed back that you are able to support trusts and some of this is supporting smaller viable hospitals. If there's an impact on an orthopaedic system in one place, how do you support that rather than change it to a deficit of the other comorbidities, and how do you feed that across?
I think that's a really good question. I mean, the national work on the getting it right first time in orthopaedics actually tried to address that issue, and I don't think it is just about smaller centres or larger centres doing more and more. It's actually about supporting a hub and spoke network around orthopaedics, and I think the specialists and the tertiary trusts are in a good place to do that and have the concentration of skills and expertise to help support smaller units using technology, but using standards, because this variation in practice is huge, and the national reports show that very clearly. This gives us the national platform to be able to do that. We haven't got the national platform without the vanguard. I think that's the leverage that we need now to take this work onto a different level.
I think it's vital to say that one size does not fit all. We've got, by using our expertise of what we've shared across the country and seen, we can see different models can deliver good outcomes for patients, and bringing staff with them and being transparent about the different models that work.
Table 18, please.
Hi, Lindsay Hughes from the AHP team at NHS England. Can you tell me how you're including rehabilitation in this model to maximise outcomes for patients?
I couldn't hear the
Rehabilitation.
Oh, yes, okay. Shall I go ahead?
Yes, come on, Rachel, on the stage.
We've been working with the Chartered Society of Physiotherapists, and they initially did a pilot study looking at rehab post-knee surgery and rehab post-fractured neck of femur, and comparing that. And that's been a very useful first piece of work, and we want to work with them more closely, rolling that experience out across the other elements. It's the failure of rehab across the country that we've seen is very overt. It cannot be denied. There is over-investment in some areas. There is under-investment in other areas. No one knows that they're doing that, and I think shining a light on it is part of what we want to bring, and rehab is clearly central to that. And we are integrated with all the various bits of the organisations.
Thank you very much for the questions. Unfortunately, the 5 minutes up, so sorry to people who had their hands up. So big thank you, please, to the Specialist Orthopaedic Alliance.